Good evening. I'm Kelly Gear-Ripken, National Chair of A Women's Journey. On behalf of Johns Hopkins Medicine's A Women's Journey, thank you for joining me this evening for our monthly webcast series, Healthy Conversations That Matter. You know, A Woman's Journey always strives to improve your well-being through health education. Did you know knee pain affects approximately 25% of adults, and the prevalence has increased almost 65% over the past 20 years? Tonight, we are joined by orthopedic surgeon, Dr. Stefan Coombs, who is an assistant professor of orthopedic surgery, specializing in hip and knee replacement. He is experienced in surgical and non-surgical treatment of injuries to the bones, joints, and muscles, as well as various replacement approaches. So please use your Q&A on the screen to ask your questions to Dr. Coombs, who will respond during the last 20 to 25 minutes of our program. Tonight's webcast will conclude at 8 p.m. I'd like to take this opportunity to acknowledge and thank Johns Hopkins University's program, Hopkins at Home, for their production assistance. And you can visit their website for additional lectures and courses throughout the year. A Women's Journey acknowledges the support of the Wiglicki Family Foundation, sponsor of Healthy Conversations That Matter. And now I'm pleased to welcome Dr. Coombs. Welcome.
Thank you, Kelly. Good evening, and thank you for joining us this evening. I am honored to be invited here to speak to you on a topic that I'm very passionate about. Tonight, we'll be discussing knee pain as it relates to knee osteoarthritis, and our objectives will be as follows. So we're going to touch on some key epidemiology trends in knee osteoarthritis, as well as some definitions. We will be discussing trends in terms of incidence, in terms of the growing prevalence of the disease, as well as touching on some numbers with regards to the future. We'll also discuss the multifactorial nature of osteoarthritis with a focus on highlighting modifiable risk factors and prevention. And then we'll discuss how osteoarthritis of the knee is diagnosed from common symptoms to examination findings, as well as the workup. And we'll also delve into the treatment options, including the spectrum of non-operative treatment to surgical management. Importantly, we will also look at the literature as it relates to sex-based differences in knee osteoarthritis. So why is this topic of importance and particularly relevant now? Within the last few years, the United Nations has declared the period 2021 to 2030 the decade of healing, of healthy aging, with an emphasis on not only life expectancy, but also quality of life, providing us with a unique opportunity to focus on the topic of knee pain in orthopedics. In the field of orthopedics, we believe that movement is life, and pain-free mobility is paramount to our physical, mental, and social well-being. But what exactly is knee osteoarthritis? So the prefix osteo is derived from the Greek word osteon and the Latin word os, meaning bone. Osteoarthritis is a degenerative joint disease resulting from wear and tear and progressive loss of articular cartilage. That leads us to ask the question, what exactly is cartilage? Cartilage is a strong, flexible, connective tissue, and it has three main functions. It acts as a shock absorber through the specific joint. It lubricates your joint and allows the bony ends to glide with little friction, and it provides support, helping to maintain the shape of the joint itself. This illustration depicts a healthy knee on the left. You can see the blue tinge on the left that depicts healthy cartilage. And on the right, you can see those pink spots indicative of a damaged cartilage with exposed bone, as seen in osteoarthritis. How common is knee osteoarthritis? I think these statistics put it into perspective. Knee osteoarthritis is the most common cause of disability in adults, and in the year 2022, there was a whopping 654 million people worldwide over the age of 40 suffering from knee osteoarthritis. Furthermore, our statistical analyses show that this number is projected to increase by almost 75% over the next 30 years. Why is it so common, and why are these numbers uptrending? There are two main reasons. Knee osteoarthritis is believed to be highly prevalent today, firstly, because of the significant increase in life expectancy. A 47% increase in the number of Americans greater than 65 and older is growing from 58 million in 2022 to 82 million over the next 30 years. Another significant contributing factor is the current obesity epidemic. Using the body mass index, which is a tool used to measure body fat based on height and weight, according to the 2017 to 2018 data, 1 in every 3 adults is considered to be overweight, and 2 in every 5 adults are actually considered to be obese. Osteoarthritis is a major source of healthcare expenditure, both on a population level as well as individually. And in the US in 2016, for example, osteoarthritis was responsible for 80 billion in healthcare spending. A study done in 2015 showed the lifetime cost for a person with specifically knee osteoarthritis is up to about 140,000. What about the projected surgical numbers? This is a graph that depicts the significant future demands in terms of projections for the number of knee replacements in the future. And even after relatively conservative projection approaches in terms of the statistics, it is shown that there's going to be a 143% increase in the need for knee replacements in 2015. So this is a very complex diagram, but I'm going to break it down. What is the pathology behind the disease in osteoarthritis? What exactly is happening in my knee? I would say it's an extremely complex process, but from our basic science studies, the knee, just like any organ, has a balance or an equilibrium that has to be maintained. There are different enzymes within the knee that help to regenerate cartilage and different enzymes or proteins that help to break down cartilage. And what we see in the pathology of osteoarthritis is an imbalance or an overexpression of the enzymes that break down the cartilage, causing what? A loss of elasticity, as well as erosion of the surface of the cartilage. Now, there's a common misconception that osteoarthritis is akin to aging, whereas osteoarthritis is more common in the elderly. It's not the same process. And on a cellular level, when we actually look under the microscope, there are many differences in cellular changes, as well as the water content, as well as the ratio of those enzymes that I previously mentioned. And in the aging process, the enzymes which break down cartilage are not overexpressed. Apart from the knee pathology, we also know that this is a multifactorial process. Both genetics and environmental determinants are involved, and the risk factors can be broken down or categorized into non-modifiable risk factors, meaning you can't change or control them, as well as modifiable risk factors, which we have the ability to change or control. We will briefly touch on the non-modifiable risk factors, but for the purpose of this talk, we should be more focused on the things that we can control, the modifiable risk factors. So some non-modifiable risk factors include age, sex, race, as well as genetic predisposition. Age is by far the most well-known risk factor for osteoarthritis. However, as mentioned before, it is not the same process. This graph shows the trend of prevalence. This graph on the top left shows the trend of the prevalence of knee osteoarthritis as you get older. The female sex is also a non-modifiable risk factor, with this study in 2020 showing that the prevalence of knee osteoarthritis in females is 1.6 times that of men. And there are many proposed reasons for this, for which we will discuss later. Globally, on a continent level, the prevalence has been shown to be, in some studies, to be increased in the Asian population. However, this is interesting because the studies have also shown that the Asian population is relatively thinner compared to other populations. And some proposed mechanisms or postulations for this include lifestyle habits such as bending and squatting, as well as increased laborious tasks, in addition to both genetic and environmental factors. Here within the US, the African American population has been shown to have a higher prevalence of knee osteoarthritis. The role of genetics is emerging as an important contributing factor in recent times, with more than 65 genes being found to be associated with knee osteoarthritis in different populations. And studies have shown the differential overexpression of certain inflammatory genes. So turning our attention to the modifiable risk factors, which we can control, obesity is by far the greatest modifiable risk factor, with updated WHO data in 2020 showing that 2.5 billion adults worldwide are overweight and 890 million were living with obesity, with a study showing that BMI, a body mass index of greater than 30, actually puts you at 6.8 times the risk of developing osteoarthritis compared to a lower body weight. And another study showed that it's a dose-dependent relationship, with 5 units increase in your body mass index. That's associated with a 35% increase of the risk of knee osteoarthritis. And the mechanism by which this happens is twofold. One, I believe, is more obvious, where there's an increased weight, you have an increased load being placed on the joints and therefore increased stress on the cartilage. The other one, it shows that in addition to that, for every pound of weight that is gained, there is a 4-fold increase of knee compressive forces. The other mechanism by which obesity increases the risk of osteoarthritis is that adipose tissue or fat is actually chemically active, and it constantly releases inflammatory causing proteins. Muscle weakness is another modifiable risk factor, as the quadriceps muscle acts as a shock absorber for both the knee joint itself and the patella or kneecap stabilizer. Occupational activities requiring deep flexion, such as kneeling and squatting, have a dose-dependent relationship with regards to the risk of osteoarthritis as well, with up to a 26% risk elevation for every 5,000 hours taking part in these activities. 1 in every 7 cases of knee osteoarthritis is actually attributed to work. This occurs in 2 ways, with either the previously described force and exertion onto the knee, but also with regards to specific injuries with jobs where there's a risk for knee injury. Some other modifiable risk factors include previous injury as well as dietary exposures. Individuals with a history of joint trauma are actually at 3 to 6 times more likely to develop knee osteoarthritis and are diagnosed approximately 10 years earlier than individuals without a history of knee trauma. And this occurs in 2 ways as well. It can either be from direct impact and damage to the cartilage, or it can also be from an injury to, let's say, a stabilizing mechanism of the knee, for example, the ligaments or tendons or the menisci, which can then cause secondary injury to the cartilage of the knee. It's also been shown, some studies have shown a weak association with Western pattern diets, such as soft drinks and saturated fats, to have an increased association with knee osteoarthritis or progression, whereas a Mediterranean diet has been associated with actually a lower risk of pain worsening as well as symptomatic forms of knee osteoarthritis. So how do we diagnose a knee osteoarthritis? Like most conditions in medicine, it starts with a history, patient interview, followed by an examination and investigation. Common symptoms are pain. Patients report a deep, dull, achy pain that is worse with activity and relieved partially by rest. Another very common complaint is extreme pain after prolonged sitting when trying to get up. And associated symptoms include stiffness, as well as mechanical symptoms of catching or locking or even instability of the knee. Patients often report a clicking or grinding sound to the knee, and some actually present with significant knee swelling, such as this diagram, showing that the left knee is much more swollen compared to the right, with what we call an effusion or fluid in the knee. On examination, patients usually have a painful gait or a limp. They have decreased range of motion or stiffness of the knee, as well as tenderness at the joint line. And another sign on exam is a deformity, which can either be a progressive valgus or knocked knee deformity or progressive varus or bowed leg deformity, as seen in these images. So after history and examination, how do we confirm the diagnosis? We confirm it with radiographs or x-rays. This image above shows two knees. The one on the left is a normal knee joint in which you have a thigh bone, a shin bone, the femur or the tibia, and a black space between both these bones. Now, the image and the rays actually on x-rays would pick up mineral, and you can't see cartilage on the x-ray. However, the space here is indicative of cartilage within the knee joint, and that's a normal knee. Now, if you turn your attention to the knee on the right, you can see that there's a complete obliteration or lack of that black joint space, which is essentially bone-on-bone osteoarthritis of the knee. With that being said, not all knee pain is due to arthritis. There are many other relatively common causes of knee pain, which can include, specific to the knee, damage to any of the structures seen on the slide, such as the bone. You can have fractures. With regards to the ligaments, you can have an ACL injury or tear. You can have inflammatory conditions or tendonitis of both the patella and the quadriceps tendon, or you can have a meniscal tear, whether it be an acute meniscal tear or degeneration over time as well. And very rarely, there's the potential of an infection within the knee as well, in addition to inflammatory causes of knee pain. It should be highlighted that the sensation of knee pain is not always attributed to a structural problem within the knee joint itself. I would say at least 2 to 3 times a week in the office, I have a patient that comes in with complaints of knee pain, and after careful history, examination, and x-rays, I'm able to diagnose them with not a knee problem. However, they can have a pinched nerve within the back or an inflamed nerve at the level of the back, and even hip pathology. The reason for these symptoms is due to what we call referred pain. And what referred pain simply means is that you have a common nerve distribution between two areas. And if you have any pathology higher up, it can be referred down, specifically in this scenario, to the knee. Now, this slide shows that a depiction of the stepwise approach in which we manage knee osteoarthritis. And it should take the course of lifestyle changes, such as weight loss, activity modification, walking aids. Then there's a step up to oral and topical NSAIDs. Then there's a step up to injections and nerve ablation procedures. And then finally, you go to surgery. There have been thousands of studies conducted to determine the efficacies of all of these treatment modalities, everyone listed here. And some have been found to be extremely effective, and some have been found to not be as effective. The American Academy of Orthopaedic Surgeons frequently reviews all the recent literature and data on different treatment protocols. And upon this review, we are able to recommend and produce what we call clinical practice guidelines to help guide practicing orthopedic surgeons and physicians with an evidence-based recommendation with regards to treatment. The treatment modalities could be classified into non-operative and operative treatment options. Non-operative treatment options include weight loss, cane use or devices such as a walker, self-management, physical therapy, muscle strengthening, braces, anti-inflammatory pills, and injections. And we will delve into the operative treatment soon. We've discussed the role of weight and knee osteoarthritis at length, but in this study, it highlights the effectiveness of weight loss in treatment, pointing out that really just 10% weight loss of your body weight can actually cut your arthritis pain by 30 to 50%. It may also slow down the progression of the disease, or in some cases, stop the progression of the disease. With the bonus being healthy weight loss is associated with lower blood pressure and a reduced risk for chronic non-communicable diseases such as diabetes and heart disease. The use of a walking aid, such as a cane, also plays a significant role in pain reduction and decreased medication consumption, noting that the cane should be used in the contralateral or opposite hand of the affected limb. The role of physical therapy in knee osteoarthritis has been studied extensively, and it has been shown to be of tremendous benefit. One strong randomized controlled trial showed that a combination of manual physical therapy and supervised exercise yields functional benefits for patients with osteoarthritis of the knee and may delay or even prevent the surgical intervention. Therapy usually involves range of motion, strengthening, as well as manual therapy, as well as aerobic activities as well. The best aerobic activities come in the form of low impact exercises, which do not put excessive pressure or stress on your knee. And these include walking, using the elliptical machine, using the stationary bike, as well as aquatherapy, as the buoyancy of the water decreases compressive forces by up to 35 to 55%. Self-management is considered an effective strategy for treating chronic diseases, including osteoarthritis of the knee. But what is self-management? It's referred to as the ability of a patient to manage diseases, symptoms, and treatments, as well as lifestyle and mental and physical changes caused by diseases. It obviously requires education and empowerment, but it is very effective and allows patients to make necessary behavior changes to improve their health. Muscle strengthening, specifically the quadriceps muscle, has been shown to reduce pain and improve function in knee osteoarthritis patients. In 2021, the American Academy of Orthopaedic Surgeons clinical practice guideline made a moderate recommendation for the use of bracing to improve function, pain, and quality of life in knee osteoarthritis. The evidence is somewhat weak, but specific types of offloading braces, which decrease forces on a specific wear pattern of the knee, can be of some benefit in terms of bow-legged patients. NSAIDs, or non-steroidal anti-inflammatories, are medications which have inflammatory reducing capacities and also pain relieving effects, and have been shown to be extremely effective in knee osteoarthritis management, so much so that the Academy strongly supports the recommendation of their use. The following is on the slide is recommended when using these painkillers, as they should not be used regularly or consistently, meaning every day, 5 times a day, 4 times a day. They should really only be used if there is a need for severe pain or during flare-ups. One should start at a lower dose and stay below the maximum daily doses. And they should also be used in conjunction with other effective treatment modalities, such as exercise and physical therapy. And it is important to note that long-term use of this type of medication should be discussed with and monitored by your doctor. These are a list of possible side effects, with more serious side effects being increased when taking high doses and prolonged doses of this medication. And these side effects include GI upset stomach, gastritis, or ulcers, and if taken for prolonged periods, can actually affect the kidneys. And I tell my patients all the time, we will be monitoring your kidneys if we keep you on this for long term. Knee steroid injections have been shown and proven to provide short and medium-term pain relief in knee osteoarthritis due to its anti-inflammatory properties, with only minor side effects, such as skin atrophy or thinning, and a very, very rare side effect of a knee infection. in 2021, a survey study done of the American Association of Hip and Knee Surgeons found that a common question that's asked is, how long are these injections going to last me? And in all the surgeons in the US, the hip and knee surgeons, this is their experience stated on this graph, which shows that about 80% or more of surgeons see a good pain relief within 3 months or less, or within 4 to 5 months. Many patients come in asking about hyaluronic acid, which is essentially the gel. It's a viscosupplementation or gel shot, and we'll call it HA. HA is a naturally occurring substance in the knee joint, and its function is to lubricate the joint and absorb shocks during movement, thus increasing the viscosity or the thickness of the synovial fluid or fluid within the joint. It also contributes to the inhibition of pain receptors and has some properties which can prevent the enzymatic sort of degradation or destruction of cartilage. In this procedure, this gel-like fluid called HA is injected into the knee joint, and the theory is that it would facilitate movement and reduce pain. The studies, however, are relatively weak, and the Academy does not support the use of it on a widespread basis. What I can tell you, though, is the studies in terms of the cost are relatively strong. One injection being quoted to be up from $300 to about $700. So it's a very expensive shot, and there's no increased benefit for the most part compared to a steroid shot, which is much cheaper. That being said, I've also had patients who've clearly stated a benefit from it. And what the studies are now focusing on are, how do we determine the select group of patients who benefit from this medication and procedure the most? So turning our attention, we've discussed all the non-operative treatment modalities, or most of them. It's important that we recognize that surgery in the form of a knee replacement, whether it be a partial knee replacement or a total knee replacement, should be considered only after all the non-operative treatments have been exhausted. A total knee replacement has been shown to be effective, reliable, reproducible, and safe in terms of producing pain relief. But what exactly is a knee replacement, and what does it entail? So there's a common misconception about a knee replacement, and some patients believe that we cut out essentially the native knee and replace everything with metal. This isn't true. The surgical procedure really involves a sophisticated sort of shaving of both the knee and the damaged cartilage to degrees of millimeters and degrees of 1 to 2 to 3 degrees at very specific angles. So what we essentially do is resurface the damaged knee to accommodate an inert metal implant used to cap the ends of the bones. And a good analogy that I use for patients is that compared to, let's say, a tooth extraction and implantation, a knee replacement is more of a crown of a tooth being put on. An alternative, less invasive surgical procedure, not very well known, is a partial knee replacement. And this involves removing the diseased cartilage of a specific part of your joint and replacing it with both metal and plastic. Studies have shown a much faster recovery in terms of a partial knee replacement, and it's also shown a faster return to work and faster return to sports with this procedure, if the candidate is appropriate. So the primary goal for any knee replacement is lasting pain relief. Other goals include improved knee function to facilitate pain-free mobilization, with the ultimate goal of what? Improving quality of life. Taking it back to the first slide. Decades ago, the length of stay in the hospital was about a few days to weeks, and relatively large portions of patients were discharged to a rehab facility. We have become so sophisticated in not only our surgical procedures, but also how we manage anesthesia, that we have certain surgical techniques, we have implants, we have early recovery, multimodal pain management. And at this point, there are many institutions that boast a greater than 50% same day calendar discharge to home, or an even higher percentage of patients are discharged within 24 hours to home. Complications after a total knee replacement are relatively infrequent, but just like any surgical procedure, there are complications related to the surgery itself and complications related to anesthesia or medical complications. Less than 2% of patients experience serious issues like knee joint infections, while major medical problems such as heart attacks, strokes, etc., are very rare as well. Chronic illnesses, however, such as diabetes, may heighten the risk of complications. And despite being uncommon, when they do arise, can cause either delay in your recovery or restricted recovery. It is important to note that every single complication listed here in this slide has been taken into extreme consideration both before surgery and during surgery, and all the necessary steps are taken to mitigate risk. This includes administration of new drugs, which we found to decrease or limit blood loss, as well as effective antibiotics and skin prep prior to making incisions during surgery to prevent infections, and the use of blood thinners to prevent blood clots. Whereas recovery is predictable within a set range, different patients recover at different paces. In general, pain and swelling within the first few weeks is expected. One is able to resume to some sort of normal activity within about 4 to 6 weeks in terms of daily activities, that is. And return to driving, which is a common question I get asked, is typically around 4 to 6 weeks as well, with one study showing in 2011 that breaking time with regards to reflexes returns within 4 weeks after surgery. But there are other factors to consider. If you are on strong narcotic medication, we don't recommend driving, as well as, however, we don't expect patients to be on narcotic medication at 4 weeks after surgery. Return to work is variable and very dependent on the nature of the occupation, with overall rates being on average about 9 to 11 weeks. High demand jobs take a bit longer to return, so around 11 to 12 weeks, and low demand or sedentary jobs are about 7 weeks. Full recovery, I would say, is anywhere between 4 months and an absolute maximum recovery up to a year. But 90% of your recovery is usually gained within the first 4 to 5 months. A common question that is asked is, how long will my knee replacement last? And a study in 2017 from this very reputable journal, The Lancet, showed that nearly 55,000 people who had a knee replacement, in only 3.9% required a revision or redo knee replacement within 10 years of surgery. And by 20 years, only 10% required further surgery or revisions. And another Lancet study in 2019 showed that 82% of total knee replacements and 70% of partial knee replacements can actually last past 25 years in patients with knee osteoarthritis. There have been many studies over the last 2 decades investigating the differences between females and males with knee osteoarthritis. These studies highlight differences in prevalence, clinical course of the disease, as well as the utilization of knee replacement as a treatment option. And some studies have even suggested that there is a sex or gender bias when it comes to intervention, just like other aspects of medicine. This graph from an article in 2019 effectively highlights the increased prevalence of arthritis as more specifically knee osteoarthritis in women compared to men. And with women being the top line, which is the dotted blue line. The question, though, becomes why? The factors are many. And because the prevalence of knee osteoarthritis increases so significantly at the time around menopause, there's a certain hormonal factor that likely plays a role. Both estrogen and other hormones seem to play an important role in inflammatory processes as well as cartilage producing processes. However, there's some conflicting evidence, so no conclusions can be made about hormonal therapy and osteoarthritis just yet. Weight gain is common during menopause, so this may actually also partially explain the rise in osteoarthritis of the knee in women during that period. And interestingly enough, they found that the relationship between body mass index and knee osteoarthritis is actually significantly stronger in women as opposed to men. A study published in 2017 found that the differences between male and female genetic expressions of the synovial fluid or fluid within the knee showed increased levels in inflammatory markers within the knees of females. And with regards to mechanical or anatomic differences, the way women tend to walk, run, stand is affected by differences in anatomy compared to men. The hips being wider than the knees puts more stress onto the knee, which can cause osteoarthritis over time in some women. One study found that the bony surface of the knees in females don't fit and glide as well as those in males. And that can put a strain on the joint as well with regards to wear and tear. Injuries to the knee are actually more common in women compared to men, and this is due to increased laxity of the ligaments due to anatomic changes as well as hormonal changes. And it's well known in our literature that females experience ACL or anterior cruciate ligament injuries in terms of athletes much more commonly than males. And people with a past ACL injury are actually 4 to 6 times more likely to develop knee osteoarthritis. So another concept that's been studied is the fact that worse clinical outcomes or course of the disease has been seen in women. And the perception of pain is obviously extremely complex and hard to measure. In fact, there are multiple sort of biological, genetic, ethnic, and emotional, and environmental and psychosocial factors that contribute to pain, and specifically pain in arthritis. But studies have shown that women do report a greater pain levels and lower functions than men when it comes to knee osteoarthritis. Now, it's been postulated that psychosocial characteristics such as depression contribute, as women have higher rates of depression, which have been associated with pain. But knee osteoarthritis also has been shown in women to be associated with increase of the same inflammatory proteins that we've described. And that inflammatory cascade or process leads to increasing pain or the perception of pain. So this landmark study 2 decades ago actually showed that there is an underuse of arthroplasty or joint replacement for severe arthritis in both sexes. However, the degree of underuse is actually more than 3 times as great in women as in men. Despite a higher prevalence, women were less likely to have undergone knee replacement. And this was despite their equal willingness to have surgery, and fewer women reported that they had discussed the possibility of a knee replacement surgery with a physician. In general, in another study, men were more likely to choose surgery earlier in the disease process compared to women, and men had higher expectations for surgical success. Women were more fearful of surgery and preferred to suffer arthritic pain rather than the risk of surgery, and also indicated they would delay surgery to await one, better technology, and also to avoid the disrupting caregiving role for dependent spouses or others. They were more concerned about being a burden on the family and wanted more information before making a decision. So, in summary, knee osteoarthritis is an extremely common condition. There are multiple treatment options available, and multiple are very effective. And the knee replacement or partial knee replacement is a reliable and safe method of treatment. And we have also highlighted that sex differences exist, which require further studies to bridge the gap in care. Thank you for your time.
Thank you very much, Dr. Coombs. That was wonderful. Just very interesting and great information.
Of course.
So we have some questions. So do you want to just jump right into it?
Let's jump right in.
Okay. First question though, what is the difference between arthritis and osteoarthritis?
Very good question. So arthritis is the global term for an inflammatory process occurring in the knee. The term itis at the end is indicative of inflammation, right? Now, there are many types of arthritis. There's osteoarthritis, there's inflammatory arthritis, as you know, rheumatoid arthritis, people have heard that term. There's arthritis related to psoriasis. And there's also arthritic conditions related to infection. We call it a septic arthritis. Mm-hmm. So the term osteoarthritis really is the mechanism of sort of a mechanical wear and tear compared to, let's say, an infective type of arthritis where you have an organism that's damaging the cartilage in a much quicker process.
Great. Thank you very much.
Sure.
So our next question is from Joanne, and she'd like to know, what can you do for continuing knee pain 2.5 years after having bilateral knee replacements?
So that's a very good question. And I won't say it's a common occurrence, but for the specialist, we see referrals from patients that have these issues. I would say, so the first way this should be approached is by taking a thorough history and exam. And what I mean by that is, in one of my previous slides, I mentioned that sometimes you can experience pain in your knees, but the pain could actually be extrinsic to the knee. So for any patient that comes in with a painful knee replacement, that's when my sort of detective cap goes on, and I start thinking about, okay, could this be the back? Could this be the hip? I have had patients who've had extremely painful knee replacements, and I've examined them and gotten x-rays of their hips where they have severe bone-on-bone hip arthritis, and you give them an injection to the hip, it completely relieves their knee pain. Okay? Now, outside of those factors, if you have fully worked up the patient, including the back, including the spine and the hips, and anything else that can potentially be happening, then you have to critically analyze the x-rays in addition to your history and exam and determine whether there's a mechanical component of the knee pain. So in some instances, very rarely, the knee implant itself could actually loosen. And these loosenings can be seen on either x-rays or advanced imaging, such as CT scans. But in all things, one thing we are very paranoid about in orthopedics and joint replacements is to rule out infection. So if I see a patient in the office that has a painful knee, that's the exact thought process that I have occurring. Now, there's a very small percentage of patients who, despite every single workup, they still suffer with pain to their knees. It's not infected. The implants look perfectly aligned and perfectly positioned, and they're not loose, and the spine and the hips are fine. In that instance, one potential treatment can actually be doing what we call nerve ablation therapy. So what is this? This is essentially what you're doing is the knee has some cutaneous nerves that help supply sensation to the knee. You can actually do an ablation therapy to basically, to put the nerves to sleep, for lack of a better term, and that decreases the sensation of pain in the knee, right? I would say that option is usually after you've exhausted every single potential cause of knee pain after a knee replacement.
Mm-hmm.
Mhm.
So, Dr. Coombs, does that go along the line, because Maureen, our next person who has a question, about nerve block treatment, is that basically what you're talking about
Yes,
right now?
yes. So
Yes.
that is a good question, and that has so what the term for it is geniculate. Geniculate means knee, right? Knee
Mm-hmm.
ablation therapy. It can either be hot or it can be cold. But essentially, what we're doing in that scenario is we are putting the nerves to sleep or the cutaneous nerves to the knee. We're killing the nerves that supply the knee in terms of pain, not function, but pain.
Right.
And that has been shown to have some good to have some good pain relief.
And is that permanent?
It's permanent to an extent, yes.
Mm-hmm. Mm-hmm.
Patients have so permanent is debatable. I wouldn't say it's permanent, however, it can provide long lasting knee relief.
Right.
Yeah.
Right.
I actually did a study on this topic a few years ago. And what it did show is when we did the nerve ablation therapy prior to surgery,
Mm-hmm.
patients experienced decreased pain after surgery and they experienced a decreased opioid consumption rate after surgery as well.
Wow,
Good.
interesting. So,
Yeah.
so with that though, what's the well, I know the difference, but what about when people are using, and Danita wants to know this, about the steroid injections,
Mhm.
like how much is too much? You can be prescribed to do steroid injections over and over and over.
Yes.
And so could you maybe speak on that a little bit? What's your opinion?
Yes. So my
Um,
opinion
mhm,
is that steroid injections should not be given any more frequently than every 3 to 4 months.
mhm.
Right? Now, we don't quite know what the exact, like the studies are inconclusive in terms of a detrimental effect and the progress and the rate and that type of stuff. However, we do know that there shouldn't be, the consensus is that we shouldn't give it up to every 3 months. Now, that doesn't mean that a steroid shot is going to last 3 months. It may last longer, it may last shorter. But my personal opinion is I wouldn't give a steroid shot more frequently than every 3 to 4 months
And
because of the potential increased risk of actually causing more harm than good.
mhm. But
Yeah.
it breaks it down.
Yes.
Mm-hmm. Yep. Interesting. Thank you very much.
Of course.
So our next question, we've got quite a few here.
Yeah.
From Peggy. She wants to know, and I've heard this quite a bit too from my friends. What do you think of repair for torn meniscus?
Yeah. So, very good question.
Kind of a hot topic, I
It is
think.
a hot topic.
Yeah.
So they're very. So we have to discuss the concept between a repair of a meniscus or a shaving of a meniscus. Okay. So there are very specific criteria for repairing a meniscus, right? And they have to do with the shape of the tear, how acute the tear is, the region that the tear is within the meniscus as well. And repairing the meniscus is usually done in younger patients and in relatively athletic patients, I would say. Now, when you get into the realm of a meniscal tear that's degenerative, similar to like wear and tear of the meniscus, as opposed to an acute injury, let's say from football or tennis or whatever, that's when you consider shaving the meniscus, right? But that's only really done after you've exhausted the non-operative modalities as well, in addition to the physical therapy, injections, stuff like that. And but the problem with shaving the meniscus is there is a slightly increased risk of progressing arthritis after the fact. Okay, so some patients actually have acceleration of arthritis after you shave the meniscus. Why? Because the meniscus acts as a protective structure for the knee cartilage. Now, there's the other thing to think about, which is a meniscal tear in the setting of osteoarthritis of the knee.
Mm-hmm.
And what the studies have shown is going in and shaving that meniscus in the setting of knee pain and osteoarthritis of the knee is no different to a placebo effect. So the academy that I mentioned before recommends against a meniscal shaving when you have arthritis of the knee. Why? Because nine times out of 10, you can't tell whether that pain is due to the arthritis or the meniscus.
Right. Right.
And the other thing to think about is the meniscus is there to act as a stabilizer, as well as it's there to help protect the cartilage, which is already damaged.
So would you say that it seems that maybe, physicians are doing less and less meniscus surgeries and
So,
doing alternative, maybe offering other alternative, treatments?
so I would say that it heavily depends on the demographic of the patient that we're dealing with. There are also
Mhm.
certain technical details in terms of whether the actual symptoms are related to more mechanical symptoms, such as locking, catching, um,
Mhm.
that sensation to the knee, giving out or buckling of the knee, then that can be potentially more related to the meniscus than arthritis. However, arthritis could cause those things as well. So I would say that doing meniscal surgeries in the demographic of patients who have arthritis is certainly decreased significantly, since those studies showed us that there's no benefit to doing it past 2 to 3 months.
Our next question is from Andrea, and she would like to know, what is your opinion about PRP? It's another big subject matter.
That's a hot topic and a good opinion,
Yeah,
good
it is.
question. So my opinion on PRP is that we still need more data, right? There are conflicting studies with regards to PRP in terms of its role in knee osteoarthritis. And my opinion is that the cost of doing a PRP injection is so significant, and I have not seen concrete evidence or data to suggest that it helps and it's consistently and reliably efficacious for osteoarthritis of the knee. So I personally don't offer PRP injections for patients with arthritis of the knee. I also think there's a misconception that PRP is going to regenerate the cartilage in your whole knee. I think some
Right.
patients believe that, and
Mm-hmm.
that's not the case. It's not been proven to do that, right? For the most part, after your cartilage is worn down, right, and you have essentially bone on bone arthritis of the knee, there's no procedure or drug or substance from the body that can be used to regenerate that cartilage.
Mm-hmm.
So the short answer is I personally don't use PRP injections in my practice.
Right.
Yeah.
So it's not even when you're doing surgeries and it's like, okay, I'm going to do I'll do PRP as well. Because you do hear that a lot. And
You
the
do.
biggest thing is because, the athletes, it's big with athletes, and it's, they're getting any type of surgery done. And oh yeah, by the
Definitely.
way, we kind of threw this into,
Definitely.
you
So
know,
so that's a very good point that you mentioned is they're athletes, right? Now,
right.
what the question I answered was related to osteoarthritis of the knee, but
Mm-hmm.
PRP has been shown to have better results when it comes to soft tissue structures, such as the patella tendon or the quadriceps tendon. So
Okay.
it's not effective in rebuilding, let's say, bone on bone osteoarthritis, but there are studies to show that it has shown benefit in the soft tissue structures around the knee. And as you rightly mentioned, those studies are more from the sports medicine literature papers.
Mm-hmm. Yep. Very popular.
Yeah.
Yep. Great. Our next question is from Ellen. She wants to know what alternatives are available in terms of exercising to lose weight when your joints hurt, when your knee hurts. I, you
Yeah.
talked about, low impact, but boy, that is a good question.
Yeah, that's an
Yeah.
excellent question because patients come to me in the office and they say, "Well, hey, doc, I'm kind of caught between a rock and a hard place because
Mm-hmm.
I I want to exercise to lose weight, but I can't exercise because of either my knee pain or my hip pain, right? Now, I would say that weight loss is a couple of things. One, in terms of exercise, the that's why the low impact activities are recommended, right? So we recommend walking, we recommend using the elliptical, we recommend the stationary bike. But late further back in the slide, I mentioned that doing aquatherapy actually significantly offloads those compressive forces on your joints, right? So that type of activity that gets your heart rate up and also burns calories is something to consider as well. Now,
Mm-hmm.
there's also the concept of, well, what is weight loss? Weight loss is twofold. It's calorie output, but it's also calorie intake, right? And
Right.
recently I told a patient, hey, I was in the gym and I used a Stairmaster for, I don't know, 30 minutes. And I don't know, I was about to collapse. It was so hard. I was on the Stairmaster for 20 minutes, right? And I looked at the calorie clock and I literally burnt like, I don't know, 300 calories. And I have a can of something here. It's almost 400 calories. So the concept of how much you burn versus very simple things that we have in our diet that we don't see the source of calories and what's in it
Mm-hmm.
is very interesting because I mean, I essentially can replace all of those calories burnt with one, I don't know, Rice Krispies or a Coke,
Easily.
you know?
Yes.
So
Mm-hmm.
I think that's another element of the whole thought process of how do I approach weight loss. And you know, there are apps that you can use to sort of track how many calories you use throughout the day in terms of foods. They're readily available. And I think that's another good option in terms of weight loss. One
Yep.
other thing that I do for my patients is I offer them a referral to see a specialist, whether it be a dietitian or our gastroenterology
Mm-hmm.
department has a weight loss clinic at Johns Hopkins. So I refer patients for help in that regard.
Right. It's an excellent, excellent point about diet. It's a great way to look at it because it's so true.
Yeah,
You're sitting there wearing out your joints over and over and over again, your knees, and meanwhile, you after you finish, you go and you eat one meal. It's
yeah,
over. You just put it all back in and more.
exactly. And the thing is, all of us are guilty of that.
We
All of
are.
us.
Yep. Nope. I did that today.
Yeah.
So we've got about 2 minutes left. Amy would like to know, so how do you feel about holistic treatments like acupuncture and cupping and all of those?
Good question. There is, so you know, there's the concept that the Western medicine, Eastern medicine, and like
Mm-hmm.
when patients come to me and ask me about it, I don't I have no I don't oppose it. Why? Because there is some literature to suggest that acupuncture helps with knee osteoarthritis, right? It hasn't been as extensively studied as all the Western medicine treatments. That's the issue with recommending things because there's mixed evidence and there's some evidence to say that it doesn't help. There's some evidence to say that it does help. Um, so if a patient comes to me asking for acupuncture for any type of pain relief, I don't oppose it. And I say if it's something you would like to try, yes. The one thing I do tell them is I can't give you definitive data to say that it works or it doesn't work, right? But I mean, I tell patients if something helps you, as long as there's no harm that I know, and as long as there's no extreme burden with regards to finances, I would
Mm-hmm.
say try it.
Yeah, go for it,
Yeah.
right? Well, on that note, this is a great note to end on. We're going to close to the 8 o'clock hour. So I would like to thank Dr. Coombs for speaking with us tonight. He has graciously agreed to respond to any unanswered questions that we've asked this evening. So in a couple of weeks, you'll receive an email with answers to any of the outstanding questions.
Thank
So
you
a
very much.
video of tonight's live stream will be available on the A Women's Journey website, hopkinsmedicine.org/A Women's Journey under videos on demand. And if you've enjoyed tonight's discussion, please check out our website, hopkinsmedicine.org/A Women's Journey for more information about upcoming live programs, webinars, podcasts, and our monthly email. Good night and stay well.
Night. Thank you, Kelly.